Good evening. My name is Paul Larner, and I'm chairman of the board of Wakefield Country Day School. Tonight, we begin the fall series of Wakefield free Zoom seminars by welcoming Dr. Hugh Hill, a resident of Rappahannock County and a physician at Johns Hopkins Hospital. With degrees in both medicine and law, Dr. Hill has been a tremendous help to our school as we planned our August 26th reopening for in-person classes. On behalf of the entire Wakefield community, I want to thank him for his many hours of advice and careful counsel. Tonight, we're delighted that Dr. Hill has agreed to update his early May seminar regarding COVID-19. Before I turn the screen over to Dr. Hill, I mentioned the schedule for the remaining 4 WCDS fall seminars, all at 7 p.m. October 7th, Ralph Bates, a resident of Flint Hill and a lifelong birder, will speak on a special topic, which he has carefully titled Birds plus Birding equal Beauty plus Joy. I'm sure you'll enjoy his presentation. On October 21, Flint Hill resident Paul Smith, a prominent Supreme Court advocate having argued 23 cases before the United States Supreme Court, will provide a most timely update on election law. October 28th, I will interview my good friend Lacey Wright about his 50-plus years as a distinguished foreign service officer, including his time in Vietnam, Italy, Laos, Jamaica, and Brazil, where he was acting ambassador. And we'll close on November 11th with John McCaslin, former White House correspondent and editor of our own Rap News. You can find more information on our seminars and listen to previous recordings at wcdsva.org. Lastly, we are a small school of very modest means, so donations to defray the cost of these seminars and otherwise support Wakefield Country Day School are most welcome at the donate button on our website. With that introduction, I now turn it over to Hugh Hill.
Thank you, Paul, and thank you. This is a great turnout, and I'm very gratified to see so many people have tuned into this. I'll try to make it worth your while. First thing I'm going to do is share screen and try to get my slideshow up. And there it should be. Paul, are you seeing the slides?
I do.
Great. Okay. So first of all, disclaimers. What I'm going to say is my opinion only. It's not Wakefield's and it's not Johns Hopkins. I do have one conflict to mention. I did buy a few shares of stock in the company that makes remdesivir when their early numbers came out. Of course, the stock has gone downhill since then, but it does create an appearance of a bias. And then finally, I would offer the disclaimer that Doc Martin did first time we did this in May, when he pointed out that whatever we say that is can't now could well turn out to be anathema next week. So I'm going to talk about where we're at, what's changed, what's been explicated, a little bit about what we've learned, and then I'm going to talk about some stuff going forward and hopefully leave time for questions. So let's see, how do I advance this? There we are. So this is a video that goes by pretty quickly. It's a 1-minute video from Hopkins that gives you the last 90 days kind of in motion. I'm going to run it twice because it's fast. Those are the deaths and now the new cases. Here are the numbers tested, and the line is the positive test ratio. Here are the hot spots in the country. Houston blows up like an atomic bomb hit it. here's some data from the states. So I know that's quick, so I'm going to run it again very briefly. But where we're at right now is just over 200,000 deaths from this. So if we make it to 280,000, if we're 200,000. If we make it to 280,000 by the year's end, that'll be an increase by 10% of the expected deaths in 2020. And since we're getting close to 1,000 deaths per day, we could very well be at 300,000 by the year's end if it continues like this. Now, that number ignores questions of how many of those people would be dead anyway of something else. Some of them might have gotten run over by a car if they hadn't been taxed with COVID. But we've also learned something about the importance of how you count. There's been political pressures both ways to increase and to decrease the number of coronavirus cases. This used to be very, very reliable information, and some people have questioned it. I think it still is pretty much so, but it's at least 2 weeks delayed because the death certificates have to go into the CDC to be counted. There's an electronic method for that right now, but it's not in use universally. Also, we are still calling cases of COVID as the cause of death in cases where we don't necessarily have a positive PCR test to confirm it based on clinical suspicion and what's going on. So let me run this real quick again, and then we'll move on. They've listed the states with the worst increase in daily rates. And I suppose most of you have read that as Europe opens back up, they're experiencing an increase in cases too. So that is a graphic way to a graphic way to show you what has been happening in terms of numbers. Let's just look at Virginia for a minute. We've had almost 2 million PCR testing encounters, and I'll talk later on about different kinds of tests and the PCR versus the antigen and the antibody. And there's been 142,000 and a half cases with 132,000 and a half laboratory confirmed. This shows you part of the problem with the data. Some of those cases have been diagnosed without laboratory confirmation. How could we do that, do you ask? Well, when somebody comes to my emergency room and it's pretty obvious that they've got COVID based on a peculiar set of symptoms and signs, and the test is negative, we usually repeat the test and enter the diagnosis. In Virginia, we've had a 5.5% positivity rate. In that video, you saw a line that indicated what the positivity rate was going through the number of cases that had been tested, or the number of tests. The 5.5% is important because we think that if you're below 5%, that means you're doing enough tests. It doesn't mean that we're trying to drive the positivity rate down by being selective about who we test. It just means we're doing enough tests. In Virginia, we've had over 10,000 hospitalizations and over 3,000 deaths. In the last day, as of yesterday, we had 862 new cases and almost 40 deaths. So we've ranged recently from 600 to 1,200 new cases per day. And frankly, Virginia has not been doing as well as we'd hoped. The number of cases is comparable to what it was in the worst days of May, June, and July. And we've had a bump in cases, in deaths per day in the last week, with a running average of over 40, 5-day running average for the first time since this pandemic began. We're doing 2.1 tests per 1,000 population. And overall, the state's percentage is down to 5.2, which isn't bad. And here we go. Now, we're in the Rappahannock Rapidan Health District. Virginia divides up the state into 12, I think, districts with multiple counties in each one. And there is a Rappahannock Health District, but that's somewhere down the river, and it's not us. You see the 5 counties that we're thrown in with to get this, to get these statistics. And in our 5-county area, you can see the numbers, the laboratory confirmations, and we're actually doing pretty good on the testing positivity rate. We've gotten enough tests done to have that down to 3% positive. And Rappahannock is, the county itself has had 64 cases and 2 deaths, and that's been pretty stable for a while. So let me go to what we've learned. The 14-day quarantine period still holds up, but we think now that you probably need 1 million viruses or viral particles, infection-capable viral particles per milliliter, per cc, to really infect somebody. And for those of you unfamiliar with that nomenclature, there's 5 cc's in a teaspoonful. So 1/5 of a teaspoonful, you'd have to have 1 million viruses in your mucus to infect somebody. And that likely happens between 2 and 5 days after exposure. You'll still have PCR positivity after that, but that may be just residual viral particles. Remember the way PCR is done, they take samples and then reproduce and multiply the gene sequences of the RNA, and so it can look like you've got a lot more than you really have. But in general, we are doing better. We've learned that this is a biphasic illness. We now think about the viral infection as being the first phase of the illness, and then the body's immune response as being the second phase of the illness, and that is the thing that's taking a lot of people away. It's the body's, you could say, overreaction. You remember reading and hearing about the storm, the cytokine storm, and we can talk a little bit about the body's immune responses to COVID and how how those can cause a lot of problems. But between the virus itself and these bodily manifestations of the immune response, it's incredible how many different ways this virus has appeared. In the early days of it, I was getting fooled weekly as to whether or not somebody had the virus, because we were realizing new symptoms. By the end of March, some ear, nose, and throat specialists had reported this odd thing with 5 cases of COVID where people had lost their sense of smell. Well, that's become one of the screening questions at Hopkins, and has been found to be pretty reliable as an indication that, yes, you actually do have COVID and not some other respiratory or associated illness. People can have gastrointestinal manifestations. They can manifest as a stroke. Heart attacks are a not uncommon feature. And some of the young athletes who are getting heart effects and heart cardiomyopathies from the COVID are having their athletic careers or their lives affected, possibly permanently. The long-term effects of this disease can be really terrible. And while we're appropriately, I think, questioning whether we should do everything the doctors recommend as a policy for our economy and our country and our society, one of the factors that I don't think is being taken into account is the economic costs of these terribly sick and debilitated people and taking care of them for however much time they've got left. It's as if we entered into the Iraq War and didn't think about the casualties from that who would survive and be left debilitated for the rest of their lives, missing limbs and that sort of thing. But we didn't do that. So the treatments have changed since we last spoke in May. Back then, because people's oxygen saturation, the amount of oxygen in their bloodstream was terribly, terribly low, and still is with this disease. It was striking. We would get people who were still talking, short of breath, but still talking to us and awake with numbers that were incompatible with life. The only other thing we'd ever seen with that kind of terribly low oxygen saturation in somebody that was not dying actively is high altitude pulmonary edema. So we were intubating them, putting them on respirators very early. And we've learned since then, somewhat by happenstance and close observation of what was happening, that we don't want to early intubate people, and they do better if we don't do that, and we just try to use high flow oxygen to keep them oxygenated. And there's a little secondary sidebar tale in that. You remember that one of the concerns about equipment early on in this is that we didn't have enough respirators and ventilators. And you may say, well, gee, I don't hear that anymore. We must have produced a lot of ventilators. Well, we did, and we did a better job of distributing them to where they're needed, but the demand for them dropped because we're trying very hard not to intubate people if we can avoid it. We learned early on that if you lie people down on their stomachs, it recruits areas of the lung that were not yet affected, and so they do better. Initially, there were questions about steroids. Is that going to allow patients to get other infections or worsen pneumonia? And we've learned through clinical trials and double-blind trials that no, people do better with steroids, especially the very sick ones. Remdesivir and convalescent plasma have been shown to be effective. They're still not approved. There really is no approved treatment for COVID, but they're in common use, and they're in common use at my hospital. And they are effective if and only if they're given early. But generally, we are doing better with this. At the time that we first spoke about this, we were losing close to 50% of the people that went into an ICU. One of our neighboring counties in Rappahannock had 10 or 11 out of 12 people that they came in and got sick die. Now we're down to about 20% ICU fatalities. So we really are doing better. We've learned that children can spread it and are more often asymptomatic. It may be that 20 to 50% of infections lack symptoms. And my little parenthetical about Christian Drosten there is to remind me to tell you about the leading virologist in the EU, who is the head of virology for the Charité Hospital in Berlin, where the Koch Institute, remember Koch's postulates, is headquartered. And he's, as well as a researcher, an active clinician. And he said recently that, you know, we say that there's all these asymptomatic people, but if you ask people 4 times about symptoms, you find out that almost all of them have had something. I don't know, maybe it's an induced memory, just to get the doctor to stop asking. So the case fatality rates back then were looking like 5%, but now they're hovering around and just a little bit lower than 3%. The IFR, the infection fatality rate, is less than 1%. And therein lies a tale and a cautionary one. The literature, including the professional literature, still is not clearly differentiating between cases and infections. In some of the reports, infections are included as cases. In some of them, cases are only people that are symptomatic. But those are the numbers that we're relying on at this point. So back then it was said, test, test, test. That's what you got to do. You got to absolutely have a test. Well, I fear that that was in part based on a naive assumption that once somebody got tested, they would get the information quickly and we could do something about it quickly. And we've learned that that just isn't true. If you get a test result 10 days after you apply for an appointment to get yourself tested, or your doctor does, it's worthless because you're almost through the 14-day isolation period. So there's a lot of emphasis now on trying to get quick turnarounds. The PCR test takes the longest, and we're going to talk some about the various testing towards the end of the presentation. And that's part of the problem, and that's all that's available to us now in our area. What we really need is a quick result. We need to trace, and we need to isolate people. We've talked a lot about age as a factor, but what we've learned is that people who are young adults who have comorbidities like diabetes, obesity, hypertension, they can get just as sick as older adults and just as quickly. And finally, we've learned that we've got to be just very cautious about the massive amount of information that's being thrown at us. There's been stuff presented as if it were scientific, which is not, and there have been a lot of studies reported with minimal number of cases. There have been models in mathematical modeling of what would happen and what they think is happening that's not supported necessarily by observations in fact, that get published and get conflated with the factual and good observations. So I urge all of you to be skeptical, as I am, of the information you get about this, and a little bit cautious, and that includes what I have to say. Just watch your source. Take your sources with a grain of salt, and be selective about your sources. Great. So the spread. Back in May, we were still fighting with the WHO. I told you that the WHO was saying it's all contact spread. That's the way it's being spread, and masks are not that important. Well, there's a lesson in that. Why did they say that? There's been some suggestion that they said that in part to avoid a panic. I don't know where we've heard that since then, but they wanted to preserve masks and PPE, personal protective equipment, for healthcare providers, and they didn't want to run on the available stores of those things by sharing the truth about how this COVID was being spread. I think there's a different reason, and a better one. The WHO and the CDC, at least until recently, consistently only want to report on what is evidence-based, what has been shown. Now, lack of evidence is not evidence of lack. So the fact that there is no evidence for something, pronouncements still come out from the World Health Organization saying, we don't have any evidence of A. Well, they don't always follow that up with saying, well, that doesn't mean A isn't there. It's just that we don't have evidence of it yet. So I think there's a good consensus now that this is not, surface contact is much less important. I know Wakefield is being careful about surfaces, and I'm glad they are, but the respiratory spread is the big deal. And we had a little kerfluffle at the beginning of this week with the CDC pulling back an announcement about aerosol spread. And this is probably still the result of some confusion about droplets and aerosols. We told you in May that we thought the droplets were the more important source of spread. And aerosolization we were being careful about, especially in hospitals, which means the difference is with droplets, they're like bigger, fatter, juicier, like little tiny balls of snot, spit. And they fall to the ground fairly quickly, within minutes. And they fall to the ground or whatever surface is under them. So contact spread is still possible, but it's much less commonly the source of infection. The concern about aerosolization is if you've got a mist of fine particles, not only does it go further, it hangs in the air longer. And there's some concern that people who are singing, speaking loudly, coughing, sneezing, yelling, are aerosolizing, putting a mist into the air. The people that I read, trust, and listen to still think droplets are the more important thing, but stay tuned. It may turn out that aerosolization is a big deal. For now, we still think 6 feet with a mask and 10 to 12 feet without a mask is safe if you're outdoors and it's not a crowd. So what's important now? Well, masks, and masks properly worn, not below the nose, but consistently and properly worn. And not going indoors with people that are not part of your pod or crowd, and especially if it's crowded there. It's probably not a good idea to, it's probably a good idea to not go indoors with strangers anyway, but that is especially important now. And the other thing that can be done now is get a flu shot, and I'll talk a little more about that later. I will share with you that I've started taking vitamin D. There have been a couple of articles about vitamin D, and the results, while not yet held up by multiple studies in multiple centers, were so dramatic, and the risk of taking it is so low, as long as you don't overdose on it, that I think that's worth doing. I've added that to my regimen. And we still try to ventilate the house as much as possible and ventilate everywhere that we are. And social distance. So social distancing. This is just kind of the Ohio Department of Health put this out as a nice way to show what happens when the mousetraps holding the ping pong balls are close together versus where they're apart in terms of distancing. And I thought that was a cute graphic to show what's going on with social distancing. So in the future, well, for now, masks, at least for the next few months, are going to continue to be very important, and possibly next year, because, well, we can talk about that when we get to the vaccines. Testing. Right now, all that's available in our area is PCR. I even called LabCorp on a couple of sources to see if there was a rapid antigen test available in our area, and not yet. There's been a very reliable, in the 90% range, reliable, that's been approved, and they're ramping up to generate, I can't remember, I think 150 million of these next month. Abbott Laboratories. It's a little credit card sized, a little bit bigger than that test you can do at home. Then you read, right now it's only approved to be done by medical professionals, but you can read on there whether or not you're positive. The amount of virus crosses a threshold and reacts with a labeled antibody, and then you get, it's like a home pregnancy test. These things are right now $5, and some schools and other institutions are testing people twice a week. And that gets very rapidly too expensive for most educational institutions. But, you know, NFL, National Basketball Association, people that have money are doing these things every day. And even if the test does have some false negatives, doing it frequently picks up the cases quickly enough to keep things under control. Finally, antibody tests are available but not being mass marketed yet because we haven't figured out exactly how to use them. If you've got an antibody test that's positive, does that mean that you are protected? Does it reach that level? We just don't know yet. There are some new treatments, in addition to vaccines, there are new treatments that are being studied that we have some hope for. There's a whole bunch of immune modulators, the molecular antibody fragments, where you give somebody an antibody that's engineered specifically. Tocilizumab, which is used for rheumatoid arthritis, is just one of them. There's a whole bunch. And there are about 6 antivirals. Usually those drugs end with a vir, like remdesivir, that are being studied. And none of them have been approved yet, including some HIV medications. So, vaccines. Right, there are at least 60 candidates and at least 6 in phase 3 trials. Everybody's saying vaccines are the way out of this, so I'm going to emphasize, take a little time with this. This is incredibly fast to get to phase 3 trials. Phases 1 and 2 are for safety. Phase 1 is usually like animal studies, and 2, you put the thing you're testing into some people and see that it's safe. And then phase 3 is when you're going to prove that it's efficacious, right? And how do you show that a virus is efficacious? Well, with a virus like this that can kill people, it would be not just unethical, it would be criminal to give it to somebody, even a willing, knowing volunteer, to see if it worked. So you can't give somebody the vaccine and then give them the virus. what you have to do is give a bunch of people the vaccine, turn them loose in into the wild, and see how many of them get infected versus the people that didn't get the vaccine. So to do that requires like 25 to 30,000 people. And so all of these companies have recruited that many people to volunteer to take the vaccine, and it requires time to get enough information to show whether or not they are immune in a real and a clinical sense, and for the statisticians to get a hold of that, to massage the numbers and to show that it's significant. So the positive thing about this is that we've been throwing money at this like crazy. And this is Fauci, Anthony Fauci's explanation of this I find most cogent. The fastest we've ever made a vaccine was 4 years. And what normally happens is the company starts the process, tests it extensively, then decides whether to go on to the next step. And then finally, they gear up to manufacturing enough to do a clinical trial or a phase 3 trial. And then and only then, after they get those results and think about them a while, do they decide to manufacture them. And starting the manufacturing process to reproduce enough of the vaccine to get it out there takes a lot of time. Well, what has happened here is that manufacturing has already started. Most of it's paid for by you and me. Some of it, a couple of companies are putting their own stuff at risk. But their own assets at risk. What happens is right now, these candidates that are in phase 3 trials, those companies are ramping up production of that vaccine, which is why they can say that it will be available, we hope, early next year, certainly by summer. So almost all of the candidates, there's one in particular that doesn't, they almost all require 2 shots, maybe 2 to 4 weeks apart. So that's going to add to the time of trying to decide whether or not they're efficacious. And all the leading candidates seem to provide both passive immunity and active immunity. And this is something that they can find out in the phase 2 trials. The passive immunity is the production of antibodies that then attack the virus or protect the cells. And we're all hoping that they'll be blocking antibodies to prevent an infection to start with. And active immunity, these vaccines teach memory T cells. Those are a form of lymphocytes that remember this antigen or this virus. And if they see it again, if it hits the body again, they say, okay, turn on the gas and make a lot of antibody. And the helper T cells get that going. Now, we don't know about the immunity after an infection any better than we do about immunity after the after the vaccine at this point. There's been at least one well-documented case of somebody getting a new infection after 4 months. At first, it was unclear as to whether they were just having the old infection that was recrudescing. I had a patient that had been symptom-free for 3 weeks and came back in, but it was pretty clear that he was in the second phase of the illness and having his immune system reacting. So it may be only for months, but because of the T cells, it's pretty clear that it's less severe on the repeat. Now, that still means that that person could spread it, could get the infection and spread it to other people, but it's less severe. And just commonsensically, we think if it's less severe, they're less likely to spread it and less likely to have 1 million viral particles per milliliter for an extended period of time. But for right now, if you're in the presence of someone at less than 6 feet and it's for 15 minutes or more and no mask, you are at great risk of getting the infection. Something like 50% of those encounters, if one of the 2 people has the infection and is shedding virus, will result in an infection in the other person. So if this is like, there are 4 common cold coronaviruses, and then there are 2 other nasty viruses, SARS-CoV-1, which was from South Asia, and MERS, the Middle Eastern Respiratory Syndrome, which is camels are the carrying agent for that one. But if you analogize from those, it could be that we'll get a mild case every year after the initial one. But for now, it looks more likely like it's going to be annual shots. For a flu vaccine, switching over to flu for a minute, for a flu vaccine, a 60% effective rate for a flu vaccine is very good. We're very happy in any year when it's 60% effective. So right now they're talking about a 50% effective rate being acceptable for this. But that means that half the people that get the vaccine will not be immune. So that's why I say we may still be wearing masks and socially distancing, even though the economy is going again at the middle of next year. So what can we do now? Get a flu shot. The combination of flu and COVID is high fatality. It's really dangerous. And it's very hard to tell them apart. The sequence of symptoms are similar, and to know which it is going to be tough. We are probably going to start at Hopkins doing what we did in March, which is everybody that comes in, we test them for both. Treatments are very different. But our Rappahannock Rapidan Health District, we've been advised by April Actor, the MPH, who is our population health coordinator, who, by the way, has done a fabulous job of keeping us informed. I know Wakefield's been in touch with her, and she sends out emails with what's going on and what's happening. And some of my presentation comes from the things that she sends out. But right now, our district has 500 free flu shots at drive-through clinics. And here are the 3 places and times. The first 3 Thursdays in October from 4:30 to 7 at 3 different places. So we need to get flu shots done. Little interesting sidelight to that. In the places where populations have been doing a good job of masking and social distancing, the flu rate is way down, which is maybe something that we should pay attention to in future years after we've got COVID under control. And let me see if I can stop this now. Give me a second and I'll try to stop the slideshow here. Click to exit. There it is. Aha, okay, got it.
Okay.
Now, and I hope I answered some questions, but if there are others, I will try to respond to them. Is that appropriate at this point, Paul?
It sure is, and thank you for a cogent presentation. I have one quick question for you, and I suspect since we've got 42 people on the call, there'll be others, but wow. My question is on the vaccines. You know, they have to be safe and effective to be approved. So, you know, how do you, if you approve something that, you know, where symptoms don't show up for 6 months, a year or 2 after the approval, how do you handle that situation? I mean, how can it be safe without a lag period to determine whether there are problems?
I think you mean, how do we know it's effective without a lag period? Safe, the things that the problems that these might cause are going to be pretty immediately obvious. They're not really going to stimulate problems that will happen later, we don't think. Now, it's a novel virus and it's a novel situation, so that's a good point. There's a thing called phase 4 trials, which the FDA often requires of manufacturers and is hardly ever done, but I expect will be done in this case. And those are the long-term follow-up studies and tracking of anything that is put out into the market. So I hope that answers your question. I've read and heard people talking about that kind of surveillance being done in addition to testing the blood of people who've been vaccinated to see if maybe they developed immunity without having any symptoms. Can't hear you, Paul.
Thank you. Other questions for Dr. Hill?
Just unmute your microphone and speak up. I have a chat question here. Go ahead. Greg,
Am I talking?
Yes, you're on, Greg.
Yes, thank you. How seriously do you take the risks with the college students returning to the classes, the Trump rallies where they're jammed in together, the Sturgis motorcycle, and people who just go to their grocery stores in Rappahannock and Warrenton don't wear masks? How dangerous is all this?
Let me try to give you a little bit of sort of data about that. One study tried to see what was different about the behavior of a pretty good sized sample of people that had COVID versus a comparison group that were comparable in terms of age and vulnerability that didn't have COVID. And they identified some things that shouldn't surprise you. One of the highest one of the highest factors was going to dinner in a restaurant inside. Common sense would tell us that we think these packed rallies outside would be causing a problem, but they haven't been as much. The motorcycle event resulted in, so far, at least one person dying who wasn't there, but the disease was brought home by somebody who was there and got sick. And so, of course, if you ask medical people and not political people, we'll say that rallies that are indoors and crowded and unmasked are just crazy. And we'll say that they set a bad example to people because we need people to wear masks and be careful. When I wear my mask, you know, it's more to protect you than me. So, you know, I don't know if people who refuse to get vaccines and refuse to wear masks, how they're going to be treated by their fellow citizens. It seems intuitively obvious that it's dangerous, and yet I haven't read any follow-up from the demonstrations or the rallies that indicate a super big increase. You know, there are super spreader events where we think one person might just have so much virus and be spreading it out so much that a whole bunch of people will get it. And that's even happened with an outdoor event that was crowded in Washington. Not sure if it's the infectivity of that person's physiology and the way they spread it, or just the volume of virus that they're putting out. But in Virginia, we've got a little bit of information about that, in that we know about the number of cases. And about 1/5 of them, about 20%, are attributed to outbreaks where there was a cluster of cases that they could attribute to an event like a funeral or a wedding or something. Now you ask about how about schools? Well, you know, there's at least one school, one university, where if the kids are testing positive, they're made to stay in their dorm rooms and they're taken care of. They don't send them home to spread the disease through their community like a plague ship sent into enemy territory. It's just, it makes so much more sense, but most of them are doing exactly what you say. And the, like at Ann Arbor, there's a 10% rate of positivity for those kids. And there's some schools where it's a 20% rate. We're seeing in the last, I think it's 10 days, we're seeing an increase in number of cases. And there's some discussion, is that the reopening of the schools, or is that the fall and the season that's causing that? And it's hard to sort those out, but I am concerned about it. I hope that's helpful.
Hugh, I've got a couple of questions that have been submitted online, I think several from our students. First question is, how do you think the vaccine will affect the younger generation and being able to fully open up the United States?
How will it affect the younger generation? We hope that the younger generation will get the vaccine and not be sources of spread by having the immunity that will keep themselves from getting infected as often and as severely. And in that sense, you know, the very, very young people, the tiny children that got this awful syndrome, it's still terribly rare. We've only had 8 cases of it in Virginia with no fatality. And young, healthy people are generally not getting as sick, although the difference, the drawing line seems to be at about age 9. So preteens and teens can get just as sick as adults. And so getting the vaccine into enough people will help the younger generation and fully open up the states, I hope, sometime next year. Paul, I have a question that came to me, not to everyone,
Okay.
that says Virginia is on the New York State travel ban list. What must Virginia do to get off of that list? I don't know. I would imagine that our numbers have to be better. One of the parameters that's being watched is that 5% number that we talked about in terms of having to have less than 5% positive tests, meaning you're testing enough people. And I think it's also seeing a fall off. The prevalence in the community is low in Rappahannock, which is one of the things that makes it safer to reopen our schools, at least in a careful way. But the places where the prevalence is high means that it's much more likely that somebody coming from that area who has spent time there will bring the disease with them. You remember back in February how it spread so quickly to the United States, New York, and especially, and then on the other coast, it's people coming back from Europe, cruise ships coming back from Asia. So that kind of spread is legitimate to be worried about. And I think if you look at the graphs of the incidence of cases in Virginia, we're back to where we were in terms of new cases at the worst of this in May and June. I have another one. I have another private one. Would you recommend that we forego going to a gym even with social distancing? I was hopeful of doing swimming indoors. I certainly am staying away from a gym, and that's my excuse for why I've gained my COVID-19 pounds. But the gyms that are reopening carefully are reporting that they are doing well and not having a lot of cases. And that involves limiting the number of people, making an appointment, being there for a short time. So if you're swimming and you're a lane away from other people and you're not going parallel with another swimmer, it seems like it would be reasonably safe. The countervailing consideration is that you're going to be breathing hard, and it's impossible to swim in a mask. Maybe put a filter over the tip of your snorkel, but I would think it's a risk, and the risk of not getting exercise is not inconsequential. Let's see. Go ahead.
Well, Hugh, I have a number of questions via chat. Do you have? You have any that are showing up?
I do. They're showing up on my screen as well, and I can address them, or you can curate them and decide which ones are.
No. You know what? Why don't I leave that to you? I think we have a few minutes left. Maybe you could answer several of them as quickly as you can.
As quickly as I can. How at risk are teens? They're more at risk than people that are staying away from public places. And somebody, I think, Barry mentioned the grocery store. They're more at risk than people that just go to the grocery store. They're not as much at risk as folks who congregate in the ways that we've talked about, and they're not as much at risk of getting as sick as people who are 19 and over, but who have comorbid conditions. Thank you, that's nice. Is there a risk or chance of mutations of this virus? Have there been any already? There have been changes in the virus. It's an RNA and not a DNA virus. They are notorious for rapidly mutating. Almost all of the mutations are lethal to the virus or cause it to be not infectious. Down mutations in terms of dangerousness and infectability are much more likely than up mutations, although it's thought that maybe that's what happened in the second wave of the Spanish flu. But they haven't had enough, we really haven't had enough of a change in the RNA virus, SARS-CoV-19 SARS-CoV-2 to say that there is a phenotypic alteration in the virus that would allow us to say it's actually been a mutation. Linda asks about the advice flying. Airlines purport to have sophisticated air filter systems, etc. I'm not going to do it. Linda, I am not going to fly. I've seen too many pictures of people packed into and crowded in an airplane. If you do need to fly, I would double mask and have my gel for my hands right there constantly, just in case I forgot. And I would wear eye protection if I had to fly too. There was a recent study that suggested that the percentage of people who wear glasses who got infected was lower than people who don't wear glasses. So there may be something to the public having some eye protection too. How long do you think it will be before schools are fully open like last year? I think not until the fall of next year, but that's a swag. Ruth asked, in addition to vitamin D, are there any other supplements that you recommend? No. Staying well hydrated, of course, and some people are recommending vitamin C, although the evidence for that is more based on a general notion about what it does to viruses and nothing specific to COVID. And the vitamin D study I'm talking about was an intravenous dose of somebody that had of a group of people that came into the hospital with dramatically better results. And in fact, it may be that those people were vitamin D deficient. And if you're out in the sun and getting a normal diet, you probably are not. We just don't know. Let's see. Oh, great. Do you think movements against vaccines could potentially impact our return to a normal society? And if so, how much? Boy, I don't know. I think everybody's worried about the hostility to vaccines that's sort of latent in the population and is always there and has always been there, fearful of them and hostile to them. Added to the notion that we can't, if people don't trust what comes out of the government for political reasons, thinking that the approval of the vaccine has been rushed because of political considerations, people not wanting to take it for that reason. Yes, the answer is yes. It could potentially impact our return to a normal society, and if so, how much? That's very difficult to quantify. Don't know. Stay tuned. And let's see. Is an N95 mask essential? How effective are the regular masks, cloth masks, etc.? An N95 is not essential. The regular masks are nice. I usually, when I'm on duty, will double mask. I'll put my N95 on and then I'll put a surgical mask over that, but that's just so I can reuse my N95. There is good evidence that the 2-layer masks are much more effective, and the dense, high density, multiple fibers per cubic square centimeter cotton, high density cotton, combined with either a satin or a chiffon layer because of some sort of electrostatic effect it has. And that's been tested on machines. So, you know, I look for those now. I've got a couple of those that I've purchased through the internet. And I would urge you to consider that one. And that gets me to the end of my online questions. And lots of thank yous, which I'm very appreciative of.
Well, thank you so much for all of your time tonight and on several previous occasions. You had a great audience, and on behalf of all of them, maybe we can give you a round of applause on Zoom, and thank you for your fine efforts.
Thank you very much.
Community service.
Thank you, Dr.
again.
Thank you all. And remember, it may all change next week.
Like a lot of things.
Right.
All right.
Good night.
Thank you. Bye-bye.
Bye.
Bye. Thank you.